Hello again, everyone. Today we're going to be covering Chapter 22. This is the physiology and anatomy of the respiratory system, which includes things like the act of moving air in and out of the lungs for exchange. That's known as ventilation. Some of the structures that are involved in that ventilation, whether it's voluntary or involuntary, and then we talk about respiration, which can include the metabolism of oxygen in order to make ATP. So we're going to talk about these aspects as well. There is a little bit of overlap with terminology sometimes, so we want to make sure we parse that out. Before we get too far along in the physiology, we need to get some physics out of the way. I call it putting the phys in physiology. The first of which is what we call a measure called an atmosphere. And at sea level, that measurement is 760 millimeters of mercury, or 1 atmosphere. It is the sum of all of the pressures of the individual gases. So, for instance, we're about 20% oxygen, so 20% of this number would be oxygen. We're about 60% or so nitrogen, same thing. So these are broken up into their individual partial pressures, and that's what we call an atmosphere. If we went above sea level, like we're climbing a mountain, that number would drop. And if we went below sea level, like the Dead Sea or Death Valley in Nevada and California, that number would get higher. What's interesting is that you can go to the very top of Mount Everest, which is the highest land point in the world, 29,000 feet or so. And the percentages are the same. It's just that the overall pressure is lower. Now let's get into some more directly physiology related. Boyle's law, for instance. Now I want you to count the number of dots. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. So there are 8 dots in each of these. That's what we're saying here, is that volume and pressure are inversely related when you have a given amount of gas. All right. So we have a given pressure here, but if we cut the volume in half, the pressure would be twice as much, assuming we haven't lost or gained any gas. Then there's Charles' law, which is sort of plays into this as well. Its volume and temperature are related. So if we increase the pressure, we'll probably get an increase in temperature because we're talking about kinetic energy with temperature. Dalton's law kind of gets back to our atmosphere here, that what we have is a combination of pressures that gives us an overall pressure. All right. And what can happen is if we change the overall pressure, we would have to change the oxygen and CO2 concentrations in order to allow us to function at those reduced pressures and so forth. And that's why, for instance, fighter pilots, they put that mask on. If you see somebody climbing Mount Everest, it's the same way. They're using oxygen bottles. Because the overall pressure is lower, we need to supplement with these things. We'll talk about that a little bit more later on. And then lastly, we have Henry's pressure, which is sort of about solubility. That is to say, if you increase the pressure of the gas in the atmosphere around a liquid, that will influence how much dissolves in that liquid. Some basic functions of the respiratory system, and then we will talk about how we achieve these functions. The first thing is the obvious one. We're bringing oxygen in, getting CO2 out. Often I will pose a question to the class, and I'll probably do that again during our class. Have people raise their hands. How many people will raise their hands and say oxygen is good? And usually most of the class will say yes. And then I'll say, well, what about CO2? Is CO2 good? And very few, if any, will raise their hands. And the truth is, both are good for different reasons. Both are as important to life as the other. It's just for different reasons. And secondly, both can be toxic if we get out of the basic paradigm of general respiration. For instance, oxygen, if you have more than, say, 1.5 or 1.6 atmospheres of oxygen under the normal pressure, you would die from oxygen toxicity. CO2 is the same way. Too little CO2 is just as bad as too much CO2. And so there's a window for this as well. So we need to kind of discard the idea of oxygen good, CO2 bad, because again, it's about homeostatic window. Here's where carbon dioxide plays a huge role. It is involved in maintaining the blood pH, somewhere around 7.35 to 7.45. The balance between how many protons we have, which gives us pH, is due to the way CO2 behaves in liquid environments and how our body handles it. So we'll talk about that a little bit. We certainly have to maintain a proper temperature and hydration. We can eliminate heat on hot days and water on hot, that sort of thing. But on the other hand, if we have dry air, or if the air is not of physiologic temperature, we need to do what we call conditioning that air. Call it air conditioning, right? Well, we're doing the same thing for our lungs. The lung membranes are very, very delicate. They're very thin. So we have to condition that air when it's coming in order to ensure that we aren't causing damage to those very delicate membranes. We certainly have some venous return. We're using muscle, skeletal muscle in your diaphragm, never mind the accessory muscles, which will involve providing pressure for a return of blood from the veins. Vocalization. Now, this is what I would call an extra-organismal physiologic mechanism. Let's say that your body is not capable of managing the threat or the stress or so forth. You can vocalize in order to elicit help from another individual. Kind of an interesting interplay between physiology and what we call psychology and sociology. We have to have defenses here. Again, very, very thin membranes, and exposing it to external environment means potential for irritants and pathogens. And so we have multiple mechanisms, for instance, cilia and mucous membranes and specialized white blood cells in order to prevent potential pathogen invasion. Anatomically speaking, we can divide what we call the respiratory system, which is the airways down into the lungs, into two major anatomical divisions. The first of which is called the upper respiratory tract. It includes the nose and the mouth and the pharynx area in the back, the epiglottis, the uvula, and the larynx, which is covered by cartilage. We refer to it as the Adam's apple. And then we have the lower respiratory tract, which includes the trachea and the bronchi and the bronchioles, the actual alveoli, and including the diaphragm as we are varying lung volume. And part of why we divide it into upper and lower is that there are very, very different interventions if we have issues with upper and lower, particularly when we're talking about occlusion or increased resistance to airflow. And we have some more anatomy, particularly the upper mouth and nasal cavity. You have these structures called turbinates, which are also known as concha, which is another word for shell. And so you have space, and then you have these turbinates, which are increasing the surface area, allowing for conditioning, also allowing for trapping of potential pathogens and connection to sinuses. Like, for instance, the eustachian tube right here goes to your ears. That allows for sinuses to equilibrate in pressure as you change atmospheric pressure. That can occur just because of the weather, but it also occurs during travel, driving over a mountain pass or climbing and that sort of a thing. So you should have some familiarity with these structures. Again, we're not going to get super detailed here, but you should know the major ones like the concha, eustachian tube. We certainly talked about the hard palate and the soft palate and the uvula before. So make sure you have some awareness here. This figure is a little bit tricky. All right, it's looking at a cadaveric, example here, which makes it which makes it kind of hard to see everything going on here. You can see the trachea right here. We've got the aortic arch going on here and several branches of the aorta. We certainly have some bronchi here, the black, so the trachea, the bronchi, and I'm not exactly sure what this structure is right here. It's tough to tell. So I'm sorry I don't have a good handle on that. But you can see the bronchi here. You can certainly see the aortic arch and the trachea. Some structures of the larynx here. Certainly the epiglottis is something we've talked about before. You've got the hyoid bone here. You've got this Adam's apple, this is also known as the thyroid cartilage. There's a ligament here between the cricoid cartilage and the thyroid, and it's called the cricothyroid ligament. You can feel a little soft spot right under your Adam's apple. This is where they would do a cricothyrotomy in the case of an upper airway obstruction. They can go lower and do a tracheostomy. That is possible. It's a little more severe, a little more difficult to do. That one's usually the first go right there. And just another cadaveric photo of some of these structures: epiglottis, hyoid bone, glottis. This is where your vocal cords are. You have the arytenoid cartilage, which stabilizes the vocal cords, cricothyroid, and trachea. Here's a quick slide on the mechanism for how we vocalize. It involves these structures right here, these vestibular folds, and the true vocal cords. What the vocal cords do is they create a sort of embouchure, not unlike when you play a trumpet or a trombone a little bit. It's kind of a similar kind of a process where air is moving across them and they vibrate, and you can vary the tension, which then varies the pitch. So when we're looking at it in a laryngoscope, what you see are these vestibular folds, which are called false vocal cords. And then you have the white, which is just visible here, the true vocal cords. What happens is overuse leads to buildup of a callus-like hyperplasia type situation that can lead to the threatening of careers for singers and so forth. And as previously mentioned, that if you feel, and I would encourage you to feel for that cricothyroid ligament, the membrane, if you will. This is often the first pass on airway occlusion, or you can do a formal tracheostomy. This one really is done more in more serious or in truly surgical situations. We've already seen pretty much all of these structures. There's nothing really here left to elaborate on. Make sure you just have be able to work down through these and have some basic awareness of where they are and if there is a specific function that we've talked about. Now, what the thyroid cartilage is doing is actually trying to protect this gland called the thyroid gland. It has left and a right lobe, has a pyramidal lobe in the middle, and this isthmus, this narrowing in the middle. Very important for maintaining proper metabolic rate, the thyroid hormone. There's a T3 and a T4 hormone. That's what this gland makes. And doing cricothyrotomies or doing a tracheotomy, that's one of the things that you have to kind of be careful of, is that you could do a surgically induced hypothyroidism secondary to the injury while doing those two procedures. And just a cadaveric image of the upper airway in this region, or just the interface of the upper and the lower airway. I don't intend on testing you on images like this, but as you get involved, particularly if you're involved in emergency medicine, or in some cases perhaps doing some gross anatomy or pathology post-mortem, you might have exposure to this sort of an image. And now moving on to the lower respiratory tract, it begins with the trachea. The carina bifurcating into bronchioles, bronchi first and then bronchioles second. All right, we're getting smaller and smaller. We certainly have membranes that we're going to be talking about in subsequent slides. Your right lung typically has 3 lobes with 2 fissures separating them. Your left lung has 2 lobes with 1 fissure separating it. It turns out that if you inhale an object, it's actually more likely that the object will deposit in the right because this angle is a little bit off. This is a little more in the vertical than this one, this bronchus. Now that we're in the what we call the pleural cavity, this is basically the space where the lungs and by extension the heart occupy. The lungs have to be maximally inflated regardless of the pleural cavity volume. It's very, very important that we maintain maximal interface between the parietal pleura and the visceral pleura. The visceral pleura is the membrane on the surface of the lungs in this case. And that space in between is known as the pleural cavity. And then there is usually fluid in there, and it's meant to be subatmospheric. So we'll get to that a little bit later, because if we either achieve atmospheric or hopefully not supraatmospheric, that will cause the lung to collapse. We call that a pneumothorax. And we do have, blood vessels. We have pulmonary arteries and pulmonary veins. The pulmonary arteries are actually deoxygenated, and the pulmonary veins are oxygenated. That's why the pulmonary artery is blue in this case and red for the veins. Now these eventually merge and then go back to the left ventricle. And we've got a main bronchus here. We do have some immune surveillance in the lungs, so there are some lymph nodes here. And that's pretty much it for this image. And again, you can see some again, cadaveric versions of this. The lungs are suspended a little bit, so there is a ligament here. You can see there's actually a depression here for the aorta coming out of the heart, kind of interesting. Different surfaces. Here's the cavity for the heart. Here's the face for the diaphragm. Again, the different lobes, the fissures, and so forth. So we start with one pipe. All right. Sometimes they call it the windpipe, the trachea. And we have 2, and then that 2 becomes 4 and 8 and 16. So we have this primary bronchus. Then we have the secondary lobar bronchi. So we have an upper, medium, and lower. All right. So you can see 2 here. Then you have tertiary that are called segmental. You divide 20 more times. To put it in perspective, the most complicated river system in the world is the Amazon, and it covers almost the entirety of the major part of South America. Only divides 12 times, and this one is twice as complex as that, so it's pretty extraordinary. You have the equivalent surface area in a fully functional lung that's a little smaller than a tennis court. It's actually quite extraordinary, and surface area is important when you're talking about exchange. Here's an X-ray image of a generally healthy lung here. You can see right and left, and you can see those divisions. You have the lobars, and then you have the segmentals, and on down into alveoli. You can just make out a little bit of the diaphragm here, and you can see the membrane, even a little bit of that fissure lobe right here. So as we're getting smaller and smaller and smaller in terms of these divisions, up to 24, we get to what is known as the alveoli, which are a very, very thin squamous epithelium. Prior to that, all the way down even into basically the terminal bronchial, you have columnar epithelium. They formally classify it as pseudo-stratified. Sometimes it's got cilia on it, and that's in order to move material out. So, excuse me. No, I'm saying that because when you clear your throat, what's happened is material has been moved up basically to your epiglottis, and then you swallow. You clear your throat and swallow. That's good for a couple of reasons. First of all, you're clearing material out of the airways, which has been brought up. And secondly, you're swallowing it, which takes it down to the most comprehensive immune infrastructure in your body, which is your digestive tract. So it's conditioning the air, it's adding moisture most of the time, unless you have extremely high humidity. If the air temperature is cooler than the human body, it would be warming that air up. If it's warmer than the human body, a little bit unusual, but it would be cooling it down. And so we call this the conducting zone, and this is where we're conditioning that air for moisture and temperature. And then we have also, we can control the dilation of these things, starting with about right around the secondary or so forth. Primary and so forth don't really have a whole lot of smooth muscle that will make a huge difference. But starting somewhere in secondary, tertiary, and down and down and down, and especially when it gets smaller, you have smooth muscle lining these bronchioles, and they are controlled by parasympathetic spinal nerves. And so when we have parasympathetic, it will cause constriction. Sympathetic will cause dilation and drying. Parasympathetic will be moistening and constricting. And so the flow of air gives rise to proper metabolic service, if you will. You will dilate those bronchioles in order to get more air and more gas exchange during sympathetic activity. Less need for airway during parasympathetic, but it also gives rise to the pathologies like COPD, asthma, bronchitis, and so forth and so forth. We do have to have a pressure difference. There has to be a difference between the pressure inside your lungs and the atmosphere for air to flow. We call that a delta P. The R stands for resistance. So if we have a variable pressure, flow should happen assuming resistance is not too high. The higher the resistance, the smaller the airway, the more occlusion you have, the less flow you have. Now they put Q in here, and I'm a little confused by that because oftentimes we talk about Q being blood flow. And that's true for blood flow, but physically it's the same thing. So we'll just refer to the flow as F. All right. Again, if you have too much resistance, you will not have proper flow. If you don't have a pressure difference, you won't have flow either. Here at the level of the alveolus, or alveoli is plural, we have four major cell types. We have four here. First of all, we have what's called the type 1 alveolar cells. It's these very, very thin squamous epithelia that are involved in exchange, allowing for exchange of gas between the blood and the alveolar air. Then we have the endothelial cells, and these are the cells that make up the capillaries. They are the cell that creates a tube that we call a capillary. Again, very, very thin. They're also squamous epithelium. We have a secretory type cell. This is the type 2 alveolar cell. And the secretory cells secrete a mixture of lipids and small peptides and ions, maybe a little water there in too, called surfactant. And so you can do a quick experiment here. You can visualize this in your mind. But if you take your finger and dip it into a glass of water and pull your finger out, you'll see a drop of water at the end of your finger. And it doesn't look very big in that context, but compared to the alveoli in your lungs, it is massive. It's like a city block, right? It's huge. If left unchecked, water would completely or almost completely fill this space, not unlike what happens in a sponge when you put it in water. And so to avoid that from happening, because we wouldn't be able to have gas exchange if this was full of fluid, call that pneumonia, we have surfactant. And what surfactant does is it breaks up the cohesion between the water molecules so that instead of a big droplet of water occupying this whole space, the water results in a thin film around the surface. That's why it's called surfactant. It breaks up the surface tension. And those are secreted by the type 2 alveolar cells. The last cell, I think it's these purple ones here. They're not labeled very well. And yeah, there it is. I see it. That's called a macrophage. It's a modified white blood cell. It has left the vascular system and now occupies areas in these alveolar spaces in order to phagocytose dirt particles or other potential irritants or pathogens, bacteria, and so forth. The combination of these small proteins and phospholipids, these hydrophobic tails, hydrophilic heads, produced by those secretory alveolar cells, gives us this reduction in water cohesion. That's also known as surface tension. It also improves what is known as compliance, that is, preventing these membranes from drying out, which makes them less stretchy. And that's what compliance is. It's the ability to stretch and expand above and beyond the basal state in order to, in this case with lungs, increase volume. The opposite of compliance, the ability to return to an original state, is called elastance. So compliance is the ability to bend and stretch. In this case, the lungs, that would mean expansion, and the return would be elastance. Let's start with this question over here on the left. What is the physiologic mechanism of gas exchange in lungs and tissues? Well, diffusion. So in order to have diffusion, you have to have a gradient, and you have to sustain that gradient, and that we sustain that gradient through ventilation and circulation. Now, normally when we have inspired air, and this is Dalton's law right here, 21% of 760 would be 159 millimeters of mercury. When we breathe that out, we're closer to 100. We're down to 16%. We've extracted a little bit. It's about the tune of 9% of the total oxygen. But here's the thing. In order to have proper exchange of oxygen, you need to be somewhere around 100 millimeters of mercury. So when you have people like with COPD, or if you have people at different elevations, like for instance, climbing mountains, you have to increase the percentage of oxygen so that the inflowing air is around 160, which means it hits around 100 or so in the lungs. Now, if you're going down deep, like for instance, say you're a deep sea diver, you know what they do? They lower the percentage, again, to get it back to around 160 and 100 inside the alveolus. The reason it drops between the alveolus here isn't just because of lung extraction. It isn't just because of extraction of oxygen. There's also dead air in there. There's also other gases like carbon dioxide coming out of the blood. So the ambient pressure in the alveolus is somewhere, again, around 100 millimeters of mercury, assuming that you're breathing in 160. All right, so that's the whole point of either augmenting gases in acute care, or scuba diving, or professional type diving where they're using different mixtures, or high altitude operations, either with pilots or astronauts or climbers. Now we have ventilation going on, and we're getting sustaining gas gradients, all right, so that we have proper oxygen moving out and carbon dioxide moving in. But we also have to have proper blood flow. If we don't have blood flow, what will happen is the blood will reach some sort of an equilibrium with the atmospheric gas, and you don't get diffusion anymore, much less taking that oxygenated blood out into the heart and the body. So we have this concept called ventilation perfusion coupling, or sometimes referred to as VQ ratio, where V is the ventilation of gases and Q is the blood flow in the pulmonary arteries and pulmonary veins. If you happen to have a high VQ, you don't have enough blood flow to match the ventilation. Ideally, we want to be somewhere around a 1, if you will. Okay, so we have the proper flow and the proper ventilation. And if we have a low VQ, that means we have some kind of an obstruction and we don't have ventilation going on and the blood doesn't engage in gas exchange. And this slide explains how, first of all, why the air in the alveolus, even if we're ventilating, is not going to have the same amount of oxygen and carbon dioxide as the atmospheric air. Now, the deeper and the more frequently we breathe, the more it will become like atmospheric air, but it never achieves it. Why? Because not all gas is moved in and out of the lungs. The lungs are always inflated to some degree. And so we have dead space. Okay, this is leftover residual gas volume in the alveoli. And there's anatomical dead space, which is where you have where these things don't get bigger or smaller. So there's air space in the tube. And like, for instance, if you were using a snorkel, like a pipe, that you would use to be underwater, that's another 12, 15, 18 inches of anatomical dead space, and that does have an effect on the concentrations in your alveolus. This is why, like, for instance, let's say you were trying, like one of those movies where somebody's hiding underwater with a straw. That can work up to a point, all right. But you get too much longer, and your anatomical dead space will exceed the ability for you to ventilate properly. Then there's this thing called physiologic dead space. Like, for instance, I knew a kid in middle school who liked to chew on those Bic pens that those little blue caps on the bottom. The little small ones at the very end, not where you write, but on the opposite side. And he would just chew on it. And then one day he noticed the blue cap had disappeared. He thought it had fallen off. Well, he'd actually inhaled it and it lodged in his lung. And what happened was the alveoli downstream of that collapsed. It was called atelectasis, where you have where you have a low VQ ratio, or in some cases a high VQ ratio. That area will collapse in order to prevent inappropriate exchange or wasted energy on circulating to an area that isn't being ventilated. Okay, that concludes part 1 of the respiratory system physiology. This will be our session 3, and then session 4 we will commence with the part 2 of this PowerPoint. So we'll talk to you soon.